back. And I know Bob was complaining about the bad weather up north, but Manny was smiling because he's down where it's nice and warm in Miami. So, Bob, I hope you warmed up with your space heater and take it away. We're really looking forward to this evening.
Well, thanks, Rick. It's a pleasure to be here. Can you all hear me?
Yes.
We
Can you?
can.
Okay. Again, it's a pleasure to share the webinar with Dr. Menga, who's one of the best partners I've ever had, an incredibly talented surgeon. We're going to do this. The format's going to be the same way we did our last webinar, where I'm going to give a lecture first. The lecture is going to run about 20 minutes or so, and then we'll turn it over to Dr. Menga, who's going to show some of his complication cases. So we're going to start off with complications in spinal surgery. I'm going to tell you that, going over my 30 years plus practicing spine surgery, we have many complications. Every spine surgeon does. And I think one of the key tenets of dealing with complications is to be introspective in your approach to the analysis when you get a complication. Always look towards yourself. What did I do wrong as the surgeon? How can I make myself better? Some surgeons are very quick to cast blame upon others. And I implore all of us to not do that and try to look to ourselves and make ourselves better. So what I did for tonight is I put together a top 12 list of reasons why surgeries fail. And this is a top 12 list that I've encountered and put together over 30 years practicing spine surgery. And what I'm going to do for the next 20, 25 minutes or so is just go through each one of these tenets and show examples of why these are reasons why operations go awry. And the first reason why we fail in spine surgery is because we do the wrong operation. Believe it or not, this is encountered more commonly than you would think. If you look at this image on the right, this is a classic case of a patient who had pre-existing cervical kyphosis, and the surgeon went and did a destructive laminectomy posteriorly and created a disaster with worsening myelopathy, worsening stenosis, and worsening instability. Here's another example from earlier in my career that was sent to me as a young spine surgeon in the Army. This is a 52-year-old male who had back pain and had classic low-grade isthmic spondylolisthesis, as you can see here on the left. This is an easy operation when done posteriorly from the spine with a decompression and instrumented fusion. But this surgeon violated all of the tenets of good spine surgery. The surgeon went in, did a complete destabilizing laminectomy in the back, and then flipped the patient over and put in these large BAK cages in the front and created a horrendous unstable situation in this patient's spine that required a major front-back revision to achieve stability. So again, this is just the wrong operation done in a patient who had a very easy diagnosis and one that could have easily been treated with the right operation. Here's another one from my practice that happened, this is about 20 years ago. It's a 25-year-old male who 10 years ago, female who 10 years ago had a fracture and became paralyzed. The patient then developed back pain in her wheelchair and sought multiple opinions. And as you can see, these are the x-rays when she came to me. She has some arthritis below her fusion, and I counseled her for conservative measures, for some pain medications, from some therapy, for ultrasound treatment. And she went to multiple surgeons, as I said, and she found one who was very aggressive and did this operation for her. Again, this is a wrong operation to do. What the surgeon did was he did an interbody fusion from the back, and he put in these flexible rods below her pre-existing fusion, and he left a segment here in between his fusion and the pre-existing fusion above. Well, what do you think happened with this? With times, this is 6 months later, the patient came back to me with incredible back pain, now bent forward in her wheelchair. And as you can see, she's developing what looks like to be a classic Charcot spine. So here she is. She's back in my office saying, Dr. Molinari, I did this. I'm sorry. I didn't take your advice, but I'm back now because I had this operation and I am absolutely miserable. I can't maintain my posture. I'm bent forward, and now my pain is worse. So this is a classic Charcot spine. You can see the Charcot deformity here. These are very difficult to treat. And I would put out there that this was caused by the surgeon doing the wrong operation on this patient. So what I did was I counseled the patient extensively, took the patient to surgery and did what I think is the most appropriate operation for a Charcot spine in a thoracic paraplegic patient. I did an anterior approach. I did a cage. I resected the deformity, put rigid instrumentation in there, put structural cages down to the sacrum, and then fused her with instrumentation down to the sacrum. And I was very happy with her results at 1 year. And you can see she has nice alignment in the coronal sagittal planes. And this I thought was a perfect result, as a younger surgeon. Well, there's nothing more humbling than long-term spine follow-up. And as Jens in the group at UW told us many years ago, these Charcot spines have high rates of revision and they're very problematic. And here is the patient at 8-year follow-up. As you can see, she Charcoted right through my bottom instrumentation and my bottom graft. She has a big defect right here. And this is her at 8 years. So what I chose to do is at 8 years that she wasn't having pain. She maintained her sitting balance and I left her alone. But there are surgeons who would have done more for this. And I tell you, this is all a result of just doing the wrong operation for our patients. Okay. The next category is operating on the wrong patients. I think it's important when we do spine surgery to operate on patients who want to get better, operate on patients who are motivated to improve themselves. We know from Fredrickson's article years ago that patients who have emotional dysfunction, problems with emotional health, they don't do very well with surgery. Patients with secondary gain issues don't do very well with surgery. And wrong patients are a major issue in the spine community. Here's a patient who was put on the table for a degenerative back operation. I would challenge everyone that this patient probably should lose weight before having a degenerative back fusion. This is an example of patients who I think are the right patients who I've encountered in my practice. On the left is a military soldier who wanted to have a degenerative spine fusion. I told him he needed to go do physical therapy. I need to make sure that he was the right patient. And he went out and got this tattoo that said, "Dr. Molinari, I'm your guaranteed player. If you operate on me, I'll get better." And I did, and he got better. On the right here is a patient who had a trauma surgery done by me. It's not the best. If you look at what he did with his back, he went and got a tattoo of the surgery. He was so happy with it. And when I looked at this, I said, "Wow, it's great that you got the tattoo." But I look at the quality of surgery and I said, well, this could have been a lot better. The screws are short, the cage is a little small, but he did fine and he was motivated. An example of the right patients to operate on when we do spine surgery. The next category is being the wrong surgeon. I think we should all ask ourselves when we project to do an operation is, am I in over my head? Can I do this operation well? Am I qualified to do it? And can I anticipate and handle the expected complications? And here's an example of this category from earlier in my career. This is a 70-year-old male who had bilateral leg pain and a classic degenerative spondylolisthesis with stenosis and gapping of the facet joints. Again, this is an operation that's routinely handled from posterior approach with screws and a decompression. But this guy went out into the community and he went to a surgeon who advertised himself as a PLIF expert. And you guys all remember back in the 90s, early 2000s, the PLIF with the posterior BAK cages was in vogue and it was very popular. And that's what this guy did. This guy went out and he took the patient to surgery and did a big destabilizing posterior operation. He resected the posterior elements to include one of the pars. He left a wispy pars, that's a couple of millimeters here, and he put these two large BAK cages in, and that was his operation. And what do you think happens? Patient wakes up and the whole thing decompensates in the coronal and the sagittal plane. Patient's miserable, presents to my office with back pain and says, "Dr. Molinari, I'm not going to let anyone else touch me. I'm miserable, but I don't trust spine surgeons. I think spine surgery is the worst decision that anyone can make." And I would say that the patient believes this because the wrong operation was done. It was done by a surgeon who, just used the same operation over and over again. And, my statement is if your only tool is a hammer, then everything else becomes a nail. But again, just the wrong way to do this operation. Another reason why we encounter problems with surgeries is our patients have unclear expectations. We're not honest in our preoperative approach. You never give a guarantee. You have to talk to your patients, make sure they understand the projected outcomes of a surgery, and make sure they know that there can be complications and they may not do well. And the perfect example of this is this article by Polite in 1999, where he looked at patients who had cervical fusions for neck pain. And he found that of those patients, about 20% were not satisfied. So that's 1 in 5 patients who had a neck pain operation with a fusion who didn't get better. And I think it's important to tell our patients before we do this that you may not get better. And the literature says that, in fact, you may have a 1 in 5 chance of still having neck pain. And now we have all these expanded indications for neck pain. And here's an operation that if it's done for neck pain, patient better know that they may not get better and they may still have neck pain. So again, one of the reasons why I think operations fail, patients have poor outcomes is because we don't talk to them preoperatively and we don't tell them the nuances and what to expect postoperatively. This is an example from my practice when I was in the Army. It's a 28-year-old drill sergeant who was on the verge of getting kicked out of the Army because he had intractable back pain. He had physical therapy, he had injections, and he just couldn't pass his PT test. And if you look at him, he's got spondylolysis at L5, but he's got a perfect disc at L5S1. I thought this guy was a great candidate for a pars repair, a great motion sparing operation. And I counseled him before surgery. I said, okay, we're going to do this operation. And here's the operation. Here are my intraoperative pictures. I resected the pars. I put a block graft in from his iliac crest. I compressed across the defect, and I got a beautiful result radiographically. He was completely fused. And I was thrilled when I got these x-rays. And this is about at 3 months post-op. But he still had back pain, and he never got better. And if you study this procedure, you realize that you can do the best operation on these patients, but they still may have back pain. And I counseled this patient extensively. He knew he could still have back pain. He stayed in the Army. He was able to function. But again, it wasn't a perfect result, but it wasn't bad because he understood that he may not get better. So again, we have to talk to our patients and make sure they understand. What about technical issues? Believe it or not, they're more common than we think. We're fallible. We make mistakes. And there are many technical issues that can happen. Over distraction, incomplete decompressions, poor carpentry. You can see here, these are just examples of intraoperative mistakes that can be made, okay? Now, this is an example from early on in my practice, and I'll show it tonight. It's a 60-year-old male who had myelopathy, and I tried to do a laminoplasty on this patient. As you can see, he's got bad stenosis, bad compression of the cord. And here's a 1990s laminoplasty where you can see the patient, well, first I'll tell you, the patient woke up, he had worsening arm pain, and his neck pain was incredible. I did a postoperative CT scan right after surgery because he had new onset right arm pain. And you can see the hinge broke off and was pinching his nerve root. He still had stenosis. So I apologized to the patient. I took him right back to surgery. I did an open laminectomy and an instrumented fusion, and he got better. So again, an honest approach. Being honest with our patients when we incur complications is incredibly important. Here's another patient that had an odontoid fracture. It's a 54-year-old male, had a previous fusion, was done out in the community with an odontoid screw. And if you look here, these are the surgeon's intraoperative x-rays. Here are the postoperative x-rays from the surgeon. And the surgeon looked at this. You could see the screw was posteriorly here. And here's magnified view. You can see the screw is posterior to the odontoid. And here's the CT scan showing fracture gap with the screw posterior to the odontoid. So this is an airball of an odontoid screw. So this patient was sent to me, still had neck pain, and the concern was there's potential for non-union, potential for instability, and I extended this up to C1, and the patient did fine. But again, just an intraoperative mistake that can be made. Another reason for mistakes is not understanding biomechanics. And one of the most common ones is this whole concept of the tension band versus bridge fixation principle. If you look down here, anytime we put anterior column support in a spine that lacks an anterior column, the spine is loaded in dynamic compressive weight bearing, and biomechanically, it's much more favorable than this construct where there's no anterior column support and the instrumentation is born in tension. So it's important to understand that. Ideally, we'd like to have interbody grafts. We'd like to have anterior column support. Here's an example of a 28-year-old male who was in the Army. This is a U.S. Army soldier. He was out of state. He had a rappelling accident, and he had a fracture subluxation injury of his spine. You can see the L1 vertebral body is compromised. It's collapsed. There's There's fragments in the canal. And this patient had an incomplete neurologic deficit, age of C, 28 years old. The surgeon at the local community hospital took the patient immediately to surgery and put 2 screws above, 2 screws below, and 2 crosslinks on this patient. So again, what I think is an inadequate construct for the patient's injury. And what happened was 2 weeks later, the patient was transferred back to our Army facility and had resubluxation of the spine. The CT scan showed that the patient did not have a decompression from the surgeon, and the patient had a complete paraplegia with an Asia A defect. So again, just failure. This is how I reconstructed that, put anterior column support in with an anterior posterior construct, but it was too late. The patient was paralyzed because I think the surgeon didn't understand the concept of dynamic compressive loading versus bridge fixation. Sagittal balance. Failure to understand sagittal balance is another reason why surgeries fail. Okay, and we know from Bridwell's article that the head should be centered over the pelvis. The lumbar spine should have about 60 degrees of lordosis. The thoracolumbar spine should be neutral. But again, you have to understand the sagittal plane to do that. And there's much more when patients are fused with significant positive sagittal balance. There's a lot of stress in the posterior elements. It's a very debilitating condition. This is an example of a patient who had an extensive scoliosis operation, and in the coronal plane, it looks fine. But when the patient woke up in the sagittal plane, it wasn't fine. There was a huge sagittal imbalance, and this patient was experiencing horrendous back pain and disability and required extensive revision surgery to put the head over the pelvis. So again, failure to understand sagittal plane alignment, sagittal plane principles can lead to complications postoperatively. One of the more common reasons nowadays, I think, for failure of surgeries is pseudarthrosis, failure of fusion. And I think that's because we're so apt to use all of these bone graft substitutes and all of these products that are off the shelf and make our surgeries easier. And I would submit that a lot of these products haven't been appropriately vetted and are prone to complications with pseudarthrosis. This is an example, again, from early in my career of a patient who had surgery in Germany. It was an Air Force pilot who had surgery in an Air Force facility in Germany. And what the surgeon did was an instrumented gill laminectomy for L5S1 isthmic spondylolisthesis. But for the fusion, the surgeon just recycled the bone and put some bone graft substitute. But you can see here, the screws failed. This is a classic non-union, and there's really nothing in the gutters here. There's absolutely nothing. So this is a classic pseudarthrosis. So again, I got an MRI on this. I wound up reconstructing this with a front back procedure, which is a major procedure for the patient. But I would submit to everyone that this could have been avoided by using appropriate bone graft in the initial surgery. So pseudarthrosis is important. And it's important for everyone to know that iliac crest is still the gold standard substance for bone fusion. Again, it has very high fusion rates, and the complication rates, if you look at the literature, this is a great article by Schnee, that the complication rate was less than 6%, and only 2% or 2.8% had pain in the long term. So again, I think there's less morbidity than what's projected out there. And I think this is a great way to achieve fusion by using the iliac crest. It's just not done. It's not done as much now as it was done decades prior. But again, I think that's a reason why the failure of fusion is a problem. The next category is inherent procedural risk. There just some procedures that we do that are dangerous and fail because they're just risky. And here's one of them, okay? This is a 35-year-old female with chronic infection. Again, I call it a level 1 trauma center. I've done it for many years, and you have to take whatever comes in here. This is an obese patient who had a bad infection, kyphosis, came in with a partial neurologic deficit, and you can see the spine is just obliterated with infection here. It's kyphosed, it's destroyed, and this is a problem, especially with the neurologic deficit. So this patient was taken to surgery. You can see from the MRI, there's bad stenosis here. There's infection present anteriorly. This patient was taken to surgery and had a posterior anterior procedure. The posterior was same day. Posterior went well, but with the anterior procedure, we lost our signals. And we lost our signals during the surgery when we were ligating the vessels over the area of kyphosis. And we quickly finished the procedure. We imaged the patient, but you can see, at 1 year, there was no improvement. So this was an incurred worsening neurologic deficit in surgery. I would submit to you that it was a vascular problem. This is a very uncommon complication that you see in spinal operations. It's been described with kyphosis and with harvesting of the segmental vessels, by Bridwell's group was harvested. It can occur. It's, almost 1% of patients that this can occur. And the risk is kyphosis, revision surgery, and a left-sided approach. So again, just an inherent procedural risk done with harvesting segmental vessels in a patient who had kyphosis and worsening infection. Here's another inherent procedural risk. 35-year-old soldier, chronic back pain, single level DDD, gets a classic posterior lumbar instrumented PLIF procedure and did very well, but at 4 weeks came back with a superficial infection. So the patient underwent IND, okay? Early on in their careers, when patients had superficial infections, we would just we would IND the superficial space and frequently would not open up the fascia if it was tight and it looked good. Well, I would submit to you all that you have to open up the fascia, you have to clean out the spine and make sure that every aspect of that wound is irrigated and debrided. Here's a patient 3 months later, comes back with back pain. Okay, you can see the MRI. The MRI looks good, but the patient is worsening back pain and fevers. And here's the patient a week later. You can see the MRI that shows an epidural abscess. The epidural abscess clearly communicates with the cage here. So what we have now is we have a 3-month-old PLIF operation that has a posterior infection, an epidural abscess that communicates with the cage. There's lysis around the instrumentation. You can see it here. Now what do? Well, what I do is I took the patient back, was able to get around the dura, take the cage out, and remove all the instrumentation. And again, just shows it's important to do a concomitant posterior lateral fusion. As you can see here, I think the reason this surgery actually turned out well is because the patient had a concomitant posterior lateral fusion with iliac crest bone graft. And here's the patient's MRI at 2 years that did well. Okay. There are other procedural risks. Here's a 78-year-old male, severe spinal stenosis, gets the dreaded dural tear. This was the worst dural tear of my career. You can see multi-level stenosis. All this stenosis was attached to the dura. This was the biggest dural tear. It spanned the whole wound. We wound up putting in 2 grafts, 2 bovine patch grafts to seal this. And what happened? A week later, the patient developed a major neurologic deficit with a pseudomeningocele. And you can see here, this is the CSF pinching the dura right here and pinching the conus. So we rushed the patient back to surgery, decompressed the spine, took out all the CSF, repaired the dura again, put another patch graft in. But again, what I'm going to tell you is this is a very uncommon complication that people don't understand. And what it is, it's a pseudomeningocele that can cause compressive lesions on the neural elements. We wrote this up. We had 3 patients out of 2,000 that had this phenomenon. So again, it's just something to be aware of, that when you get an incidental durotomy, it can actually create a neurologic deficit. Okay. Another category is just bad luck in surgery. It's a 55-year-old male who had a routine posterior cervical decompression from myelopathy, and 4 hours later became paraplegic with this massive epidural hematoma here pinching the cord. This patient required return to the operating room and had a decompressive procedure performed and regained neurologic function. But again, this patient was dry during the surgery. We had a suction drain in place. Everything looked good. And 4 hours later had an epidural hematoma and had to be rushed back to surgery. This is an anticipated complication from a simple lumbar decompression where the patient had pre-existing coronary artery disease and developed a myocardial infarction in post-op day number 1 that required level 1 anticoagulation. Look at the extensive epidural hematoma here that came all the way from the sacrum all the way up to the bottom of the cervical spine to C6. This patient was acutely paralyzed in the middle of the night and required an emergency operation with a laminectomy from the sacrum all the way up to C7 and regained neurologic function. But massive hematoma from anticoagulation. Okay, so again, we wrote up that suction wound drains. Just because you put suction wound drains in doesn't mean that they're going to prevent hematomas. Okay, and the other factor to consider here is sometimes when we do surgery, it's very difficult to control bleeding. We operate on trauma patients. Some of these patients come in on anticoagulation. You do a trauma operation on them and you just can't control the bleeding. What we figured out over the last 2 decades is that there's this perfect use for the back dressing in these patients who you can't control the bleeding on. You put a vac dressing on them, you leave the vac dressing on for 3 to 7 days, and you take the patient back and you close them secondarily. We wrote this technique up, and here's an example of just how the vac is used. I think this is an incredible tool for preventing hematomas, and one that we figured out over the last 2 decades here at the University of Rochester. But the use of the vac, I think, is very important. Okay, now there are some cases where you just have some bad luck, and this is one of them. This is a 58-year-old woman who fell down the stairs. She had a cervical fracture, just a fracture, subluxation injury. You can see this posterior elements fractured here. She had ligamentous injury. She's totally neurologically intact. She had imaging done and surgery done within 24 hours of her injury. So she broke her neck. She comes in. We fixed her right away with posterior instrumentation. You can see here's the posterior instrumentation done. This is 24 hours from her injury. Okay, we got her up right after surgery. And what happens on postoperative day 2? She has a massive pulmonary embolism while walking to the bathroom. I would argue that this is incredibly uncommon, and it's just a case of very bad luck despite the best medical care that you can provide. And here she is. This is her a week later. She underwent perioperative demise. She developed ARDS, was put on ECMO, and unfortunately passed away. But I look at this and I say, what was done wrong here? We imaged this patient right away. We took her right to surgery. We got her right up. What was done wrong? And what about the whole concept of using chemoprophylaxis and prophylaxis in trauma patients? Well, if you look at the study of the members of the spine trauma study group, most of them agreed. There was complete agreement. There's no need for chemoprophylaxis in patients who have neurologically intact cervical injuries and who are fixed right away, which is what we did. So again, this is incredibly rare, whether you use mechanical prophylaxis or chemoprophylaxis. The incidence of DVT is rare. But you have to have a high index of suspicion, and you also have to have some luck. Now, bad luck doesn't explain everything. I would argue that that was bad luck. It was horrendous outcome for the patient, the family, for us. That's bad luck. I thought we did everything right. But here, this is a surgeon in the community who referred this patient back to me and said, Dr. Molinari, this is just a case of bad luck that I had. It's a 62-year-old male with myelopathy who the surgeon went in and did a laminoplasty operation. And when he referred the patient to me, this is what the patient looked like. And he said, oh, Dr. Moore, it's bad luck. Patient's not happy with me. Can you fix it? And I looked at this and said, sure. I took the patient on and I looked at this and I said, I don't think this was bad luck. I think what happened here is this patient had pre-existing instability, okay? And the surgeon missed the instability preoperatively. So again, you have to do meticulous pre-op planning. You need flexion extension views. You need your CT scan, sometimes your MRI, and you have to plan these operations and do the right operation. But this wasn't bad luck. This was just the wrong operation, which was fixed with a major anterior and posterior procedure, and the patient did well. So here's one more example of bad luck from my practice. 65-year-old female, back and bilateral leg pain, has a classic degenerative spondy above a sacralized L6 vertebrae. We would all conclude that this is a classic indication for what I did, which was a posterior decompression and instrumented fusion. And here it is. And it looks great, right? Just 2-week post-op film. There's the sacralized L6 vertebrae. But look what happens at 4 months. Patient comes back. Dr. Molinari, my back pain is worse than it ever was. It looks like she fractured right through that sacralized segment. If you go back and look at it, none of us would fuse this. Now look at this thing. None of us would fuse over this sacralized disc right here. But look at this. This completely fractures through. It comes off. Here's the X-ray. You can see on the CT scan, there's the fracture. And again, this patient required a revision surgery with extension down to the sacrum, and the screw that screws L5 through S1. And the patient did fine with that. But again, as I said, there's nothing more humbling than long-term spine follow-up. Here's a patient at 2 years doing well, okay? But here's the patient at 8 years. And what happened at 8 years? She has degenerative transition syndrome, stenosis above and requires extension all the way up. So again, if we fuse and change the biomechanics of the spine, we have to expect the complications of transition syndrome. Again, this patient did fine with a third operation, but it's just a ramification of what we do. Now, what about oversights? Okay, you bet, oversights. Here's a head position complication with cervical fusion. Okay, when you do a cervical fusion, it's important to keep the head in a neutral position. But this was a case that was done early on in my career. It was an 80-year-old woman in the middle of the night, had an odontoid fracture where we lost fixation at C1. We carried her up to the occiput, but we fused her in flexion. And when she woke up, she lost her airway and needed a trach to get her airway back. So what we did is we took her right back to surgery and we fixed her head position to put her in neutral. But this is just oversight that can happen when complications get too complex. Okay, and how do you prevent this from happening? I love this Frank Phillips article that talks about occipital cervical neutral with this 46-degree angle from C3 up to the foramen magnum. And again, another way to just make sure you have good occipital alignment is to just look at the patient before you do your surgery. Okay, so finishing up here, hey, another example of a mistake is just oversight. You think something is an easy case and you get in, and it actually turns out to be more complicated than you think. This is a 75-year-old patient who had myelopathy, who had a routine posterior cervical exposure for myelopathy. And what happened? There was a vertebral artery injury on exposure. You can see right here, this is the repair of the vertebral artery intraoperatively, but the vertebral artery is nowhere where it's supposed to be. It's through the posterior elements posteriorly. This is the patient 6 months post-op. You really have to know the course of the vertebral artery, especially when you operate at the cranial-cervical junction. Here is the case where it's tortuous. It can be aberrant 5% of the time. We wrote this up. Jens, you help us write this up where, you can have vertebral artery anomalies, and you can have injuries up to 2% of the time. So again, it's important to know the course of the vertebral artery before you operate. Okay, the last category, and I'm going to finish up with this case, is misdiagnosis. Nobody wants to admit that they missed the diagnosis. Nobody does. All of us have an ego, and none of us wants to say that we made a mistake. But really, it's important to be introspective when you have your complications and to analyze why surgeries fail. And here's a patient of mine back in 2004. It's a 58-year-old male with back pain, has some stenosis right here at L3-4. Okay, has a little bit of motion there, and underwent a classic posterior fusion and decompression and did quite well, in 2005 with this operation. But what happens, like anything else with long-term spine follow-up, after fusion, they can develop degeneration above or below. And he started to develop a transition syndrome below the L3-4 fusion. You can see here, he's got stenosis, he has a sepsis, he has some gapping, and he has some back pain. So he returned to me, and I said, okay, we're going to treat you conservatively back here in 2008. It was 3 years post his initial fusion. Well, here he is in 2012. His back pain got worse, and it's all localized to his low back. He still has the degenerative spondy there, and he's begging me for surgery. And this is him, in 2012. Here's the repeat MRI in 2012. Here's his stenosis still there. There's his spondylolisthesis. So I looked at this and said, okay, this is a classic degenerative back operation. We'll just extend him down and we'll get him better. And that's what we did. So here he is. I extended him down, okay? And this is the day of surgery. I extended him down, and he's better. Again, here's his preoperative MRI. I don't think any of us would argue about this indication. He has stenosis. He's had pain for several years. He's failed conservative measures. Here's his MRI. So he has the operation, and what happens? What happens is he wakes up, and this is his 2-week follow-up. His back pain is horrendous. It's Dr. Molinari, I'm miserable. Something's happening. Here are his x-rays. What's going on here? He's got complete collapse of his L2 vertebral body and his L1-2 disc space above the operation I just did 2 weeks ago. Here's a CT scan. What's going on? He's got this huge destructive process. This is an infection. This is an infection, and this is an infection that occurred above a degenerative operation. You say, well, how did this happen? Here's his MRI that was done 3 months prior to his operation. The read of the MRI is degenerative problem with stenosis at 4-5. I don't see evidence of infection. Maybe if you go back here, you're looking to say, could this be anything right here? Again, it's read as normal. None of us saw this. His x-rays were normal. So again, What do you do now? Here's a guy with an infection above his fusion. He's upset because he just had surgery. You have to have a long talk with your patient, make sure the patient understands. I went over all the images with the patient, and the patient decided to let me do his revision operation, which I did with an anterior procedure and a double cage, with a cage and a double rod construct. And I said, we have to finish this. He was happy with this operation. And I said, we really have to back this up. He chose not to back it up. He said, Dr. Molinari, I'm done with surgery. It's the only patient with a two-level corpectomy that I didn't back up. Here he is a year later. He actually did very fine and his outcome was good. But this is a classic case of a misdiagnosis, and it can happen to all of us. And I would, challenge all you, look at your careers. This happens to everyone, but most people don't talk about it. Okay. So in closing, I think when you do spine surgery for 30 years, you have to be prepared for anything. Okay. The lessons that I've learned is you got to meticulously pre-op plan. You got to look at everything that can possibly happen. You have to have liberal use of your preoperative images. You have to have a game plan with a bunch of different options. You have to be able to anticipate the worst possible outcome, and you better be humble because despite your best efforts, bad things can happen, and you have to be able to communicate those with your patients, be honest with your patients, and talk to them about it. And oftentimes they'll listen to you and they'll let you proceed. And again, it's just always between you and your patients. So that's all I have tonight. I think you have to be introspective when you deal with these. These are devastating complications that I showed tonight, but you also have to take care of yourself too, because there's no medical school class on how to deal with complications. These cause harm to your patients, they cause harm to their family. But if you really care about your patients and practice medicine correctly, they should harm you too. So again, psychologically, they can be debilitating. So you got to take care of yourself also. And that's all I have. So thank you. We'll go on to Manny's cases now.
Well, that was great, Bob. Very, very comprehensive. Manny, you're going to have to talk fast and show us his cases.
Exactly. Yeah, no, that's excellent, excellent talk, Dr. Molinari. Always something to learn from you. I've had you, you've been a mentor since I was in medical school, and I appreciate everything that you continue to do and how you continue to teach us. So I'm going to go on to a few cases, and I think some of these cases would go over some of the key points that you mentioned. So to get to the cases, so first case, an 81-year-old male who presented with progressive stoop posture, back pain, difficulty looking up. He works as a civil engineer. Even at the age of 81, is still actively working. And he said that his biggest problem is when he works on commercial buildings. When he presents to the buildings, he's not sure if his clients trust him because he can't look up to the high skyscrapers. So inability to do his job. Past medical history, well-controlled diabetes, basal cell carcinoma, had a previous L45 and L5S1 ALIF, and T8 to S1 posterior spinal fusion performed in 2008 by another surgeon. DEXA scan was normal. Physical exam besides his sagittal imbalance with stoop posture, difficulty with his ADLs, decreased walking distance, could not walk for more than 10 blocks due to his posture. 3 to 4 year history of progressive deterioration of his posture. So here is x-rays when he presented to me. And he had gone back and to see the surgeon who performed his surgery, and they told him there's nothing to do. He saw another surgeon somewhere here in Florida, and they discussed performing cervical surgery to correct his head posture. And finally, he ended up with one of my senior partners who told him and recognized it wasn't a cervical issue, but more of a poor sagittal alignment of coming from his lumbar spine, and recommended he come see me to consider revision surgery. So when he presented to my clinic, measured his sagittal parameters, pelvic thoracic kyphosis 48 degrees, which is good. Lumbar lordosis 25 degrees. But you see a significant PI-LL mismatch. SVA of 19.5, T1P of 41 degrees. So these are all factors we know have a high correlation with health-related quality of life. He also had some loosening of his S1 screw, so technically had distal junctional failure, which was likely contributing to his leaning and stoop posture. So discuss this with him. He's 81 years old, otherwise healthy, besides his diabetes, which is well controlled. Despite the normal bone density, if you measure it, his Hounsfield unit was okay, not great, more on the osteopenic side. So we discussed the goal in this case would be to, and he was willing to proceed with surgery because one of those cases he felt he really could not live like that. The goal was to restore his lumbar lordosis and his spinal alignment, and this could be accomplished through a three-column osteotomy, which ideally should be maybe at L5 or S1, but given the screws anteriorly at L5 and L4, I felt it was best to do it at L4. Revise the hardware, correct some of the loose screws and distal and extend them distally to the pelvis. And also discuss quite extensively the potential complications that come with this surgery, as Dr. Molinari stressed. I think having an open discussion with the patient is very important. So I took him into surgery intraoperatively. So it is the fluoroscopy shot prior to the localization and before the osteotomy. Everything went pretty smoothly. Revised the screw, extended him up to T3, and then it came the osteotomy. So took out the L4 screw, pedicle screw, and began the posterior column, three-column osteotomy. While doing the osteotomy on the left side, even before taking on the facet joint on the right side, as soon as I completed the PSO on the left side, he started collapsing. Luckily, at that point, I told the fellow already to get a temporary rod to place, which I was thinking I'll be placing the temporary rod on my side, the left side, before going on to the right side. But as soon as I completed the PSO on the left side, he started collapsing right away. So luckily, the fellow was bending the rod, so immediately placed the temporary rod. And at that point, just looking at the spine clinically, say, well, most of the alignment has been restored. And do I really, so I'm thinking, do I really need to do a complete PSO on the contralateral side? I used the Woodson and I checked the nerve root, and the nerve root was completely free. And now I'm thinking more of, okay, I just did a three-column osteotomy. I didn't have to take out a facet joint on the contralateral side or take it out completely. And I didn't have to take out the pedicle, and the patient has already corrected their lordosis. Do I really need to take down the pedicle completely? And the nerve root is completely free. So maybe I'll get away because I'm thinking now fusion. If I can maintain as much bone as possible on the contralateral side, I can still maintain. There's a better odds of fusion. So I placed the harms cages, went to the contralateral side, and made sure the nerve was completely free, and locked everything in. Put in the four rod construct above the osteotomy side. Everything looked great, and took the patient back to recovery, and he was extubated. On post-op day one, the patient got out of bed, ambulated, very happy with his posture, happy with his symptoms, and he was very grateful. On post-op day two, he started developing ileus. And while laying in bed on post-op day three, when I came to round, he said he felt a snap in his lower back on the right side. And that was it. He said, I felt a snap and there's a little bit of pain on my lower back. I said, okay, checked his exam, 5 out of 5 strength. He can lift his leg. I mean, this guy was very strong. Laying down supine, was able to lift his leg all the way up. No leg pain at all. No weakness in his leg. No radiating pain. Post-op day four, he got out of bed and he said every time he got out of bed, he had severe low back pain, very severe pain that made him like shaky, but no leg pain at all. And so because of that, he was reluctant to work with physical therapy every time they came to work with him. And on post-op, so with the ileus, he spent a little bit more time in bed. At one point, he had a rectal tube, and then the ileus resolved. But because of the severity of the ileus, so he was still while in the ICU. They obtained a CT scan. The CT scan picked up for the ileus, picked up a PE. So a CT chest was obtained to definitely make sure it was a PE, and it confirmed it was a PE. He was placed on on heparin drip for anticoagulation. Post-op day 7, he reported improvement in his pain, but still had and said he was able to ambulate more with low back pain, but still no leg pain. On post-op day 9, he continued to report improvement with his pain. I think on post-op day 9, I had another scoliosis case at the Jackson Memorial Hospital between the two hospitals, which are like 2 blocks away from each other. And so I didn't get a chance to see him during the day since I was at the other hospital for most of the day. But when I left the other hospital, I gave him a call. I called him on my cell phone. I say, hey, how I was planning to come by and see you, but we had some delays and I'm leaving the hospital late. But just wanted to check up on you. How are you feeling today? And he said, well, I'm doing well. I think I'm getting better. But I still get some pain on my back, and sometimes it can be severe, but I think I'm overall doing well. And I think part of the reason he actually said that is because I told him if he continued with that, with the symptoms he was having, we may have to take him back and explore the wound. Even though he's on heparin drip, there's no concern for increased output from the drain. But on those CT scans that we obtained because of the ileus, I can see the fragment, and I'll show you here the fragment of bone. So this is the left side where I completed the osteotomy. On the right side, you see how close this is to the nerve. But he reported no leg pain at all. So that's why I was initially, I didn't think he needed to go back. But he said, "Oh, I'm feeling better. I don't think I want to go back to surgery because I'm actually feeling better. I'm walking better." But I told him I felt he should be walking much better than he was walking. So when I got home that night, I think it was about 8 p.m., I pulled up my computer to look at the physical therapy note because despite what he was telling me, I felt there was some aspect of it. He was reluctant because I told him that we may have to go back to surgery. And I came back, I pulled up my computer and I looked at the physical therapy note, and the physical therapy stated that yes, he was able to walk, but while he was walking, he kept reporting severe back pain. So he didn't walk as much as he did the day before. So I called him back and I said, "Hey, I just reviewed your note and it looks like you're not walking as good as I expect you to be walking. So we're going to make you NPO. And this is Friday night. We'll make you NPO Friday night and consider surgery on Saturday morning, depending on how you're doing." And he said, "No, I don't think I want to do surgery. I think I'm doing fine." I said, "Yes, I understand, but we're still going to make you NPO. And I'll come in on Saturday and we'll see how you're doing." So Saturday morning, I got in at 6:30 in the morning and I told him, "Get out of bed. Let's do it. Let's walk together since you say you're feeling better." So we get out of bed and we walked into the hallway and he said he's feeling better. He's taking more steps. And on the way back into the room, he said for the first time, he said, "I'm feeling some pain in the front of my thigh and also on the side of my thigh." I was like, "Well, just because of that. And also, I think you should be walking much better than you are right now. I think we should go back to surgery." And he questioned why. I called his wife. I discussed it with his wife, and he said, "Okay, I trust you. Let's go back to surgery." And we took him back to surgery and resected that fragment. And he was able to walk a lot better, and the pain completely resolved. And this was his final fixation the last time I saw him in clinic. So he's right now maybe about 4 months from surgery and is doing very well. But we're able to restore his alignment and took away that fragment. So the learning point from that case, at least from doing that, was as Dr. Molinari said, you have to be truthful to yourself, introspectively investigate, and try to figure out what is going on. I thought I would get away with not completing the PSO because I'd achieved the correction, but also recognizing after we got the CT that despite not complaining of the leg pain, I think part of it is pain was so severe that it really didn't care to think about the distribution of his symptoms. And recognizing that taking him back to surgery was the best thing because I felt he should be walking much better than he was. Quickly go over the next case. I have two other cases, but I think I'm
Are
going
we
to
going to
skip.
talk about these, or are we just going to present and
Sure, we
like,
can talk about this
is
actually.
this like
Maybe
is this just like a mechanical wheelbarrow thing where like what you can do? Like at the end of the day, was the patient happy he actually did this operation, and were you at the end of the day happy? And I mean, when you do these kind of surgeries on 80-year-olds, do you tell them they're going to have 2 to 3 complications and likely have reoperations? Because this is what we see in these conferences and even at our place, the deformity guys show these cases, and we know that part one is usually ends up being a part 4 or part 5. So I mean, just kind of give us the 40,000 foot view.
Yeah, so I told him there's a 100% chance of complication with this surgery. I told him for the first couple of weeks he might regret having the surgery, but he was at a point he felt he needed to have the surgery because he can function with his regular daily activities, and also he couldn't maintain his business, not being able to do his job, and so he understood that this is something that he was willing to proceed. Overall, at this time, he's very happy. Immediately after the second surgery, it was done on Saturdays. And Saturday night, he actually called me on my cell phone and said, "I feel great. My leg pain is gone. I've been able to get out of bed." And to date, he's doing very well.
And do you use some of the metrics? I mean, obviously, this guy is a very robust 81-year-old. Do you use some of these metrics like frailty indexes and things when you decide, like, okay, it's really not worth it to correct this deformity that I didn't do, it was done in the community, but the risk of doing something more is worse than the risk of just leaving it alone.
Yes, we certainly took all of that into account. And even as I mentioned, despite even especially his bone quality, because we know we're still not done, right? There's still potential risk for him coming back with proximal junctional kyphosis or other potential complications, even hardware failure, even though he's 4 months out and still and doing quite well. So yeah, so we took all those things into account and discussed that with him.
And then one other quick question from a biologic standpoint, because we're seeing this in the arthroplasty world a little bit, and we actually learned this from the revision lumbar world. Do you culture these patients and then hold on to their cultures 2 to 3 weeks to see if they have like C. acnes and biofilm issues and things like that?
No, in this particular case, no, I didn't. Yeah,
Thank you.
thank you. Any other comments about this and management of this?
No, it's a tough case, but you sort of illustrated the points that Bob was talking about. You got to talk to the patient and you have to own up to your complications, got to explain to the patient, what the pros and cons are. And, it's a mutual decision. It never feels good, Manny, but, the ultimate result was that he's happy and that's most important and that he's doing well.
And at least you recognize that it was lumbar sagittal malalignment that was responsible for his looking down on the sidewalk and saved him from a cervical thoracic osteotomy that would have been a real disaster. So,
All right. I think for the sake of time, I think I'll go to this other case. I know I've discussed this with Dr. Molinari. I think may have presented this before, but I think it's a learning point. I think there's a lot to learn from this, especially as we talk about risk for failure and at what point do you say no more surgery? So this is a 79-year-old male. I saw this it came in during COVID, similar back pain, progressive pain, inability to, he felt he was having significant difficulties with living his life and wanted to have something done about this. Failed conservative management, uh, pain isolated down to the L4 and L5 nerve distribution, normal strength with intact sensation and some positive findings on physical exam, but with progressive symptoms despite conservative management. So he opted to proceed with surgery. And here is X-ray. So he has a grade 1 spondylolisthesis at the L4-5 level. Here is the MRI showing the mostly severe foraminal stenosis bilaterally at the L4-5 level, and symptoms consistent with the L4 radiculopathy. So this is during COVID. We're limiting the admissions at the hospital and only surgeries that were absolutely necessary and based on his reported symptoms and difficulty with his life. So it's surgery, but hoping for maybe a short surgery. So we discussed the option and the hospital is allowing you, if you can do maybe 23-hour surgeries, you can do those because trying to limit the length of stay. So the goal was anterior lumbar antibody fusion, followed by a second stage perc surgery on a later date. So he came in pretty straightforward. ALIF was done at the L4-5 level. Symptoms completely resolved. It was doing great post-op day 1. The next day he went home and was doing very well. I spoke to him a few times while he was home. He was doing fine. He came back to the hospital for the perc surgery. On the day he came back for his percutaneous hardware placement at L4-5 level, he reported that he had been having some worsening back pain over the past several days, which immediately made me think, okay, maybe something happened with the hardware. Maybe the hardware failed. Maybe he had fracture subsidence. Even though intraoperatively his bone quality felt pretty good. So took him to surgery, placed him prone. This is in the pre-op area, placed him prone. And the first thing I wanted to do was get fluoroscopy shot to evaluate his bone, to evaluate the hardware, make sure there was no failure. And as you can see, he had subsided at the L4 level. And the cage looked like it slightly, not really migrated, but collapsed into the L4 level and likely source of his pain. So because of that, I felt just a posterior non-fusion percutaneous instrumentation alone will likely not be adequate. And he needed fixation, adequate, at least good adequate fixation, and also just to explore to make sure that he hasn't developed recurrent stenosis. So opted more to do an open surgery instead of a percutaneous surgery and decompress him. So went back, placed the screw at L4, placed the screw at L5, and the bone quality was really bad, very poor bone quality. So I decided, okay, we'll add one more level above and one more level below, and felt the fixation was well. Post-op day one, the guy was doing very well and felt like he was doing quite well, and he got discharged home on post-op day two. Low back pain mostly resolved. Leg pain is resolved. Came back 2 weeks for his post-operative visit, and you can see the screw is cutting out at the top of the construct. The rest of the alignment is maintained. No leg pain. He just had pain at the top. No falls. He's just doing well. He reported no back pain. 6 weeks post-op, the screw is cutting out even further. So he said he really didn't have any significant back pain, but mostly he felt like something was poking him in his back whenever he lay down, which was likely the screw moving back and forth each time he lay down. And so we discussed treatment options and got a CT scan. This at 7 weeks. You can see the screw is clearly cut out of the bone at the top of the construct, and there's loosening of that screw. Occasional back pain when laying down, no leg pain, and he said overall he was doing just fine. This is the CT again, just showing you the coronal and the axial and sagittal views, showing you the loosening of the screw at the top. So use the CT scan to measure the Hounsfield unit at the top level. And as you can see, his mean Hounsfield unit was 38 over the right side and 9.4 over the left side. So we discussed treatment options. His DEXA scan, he had osteopenia, but based on his bone quality during fixation, I felt it was pretty poor. We know the DEXA scan is not very accurate for patients with previous surgery and also patients with degenerative spondylosis or scoliosis. In his case, more degenerative changes. So we discuss various options. You can extend this, but there's high risk that you extend this and it fails, and then you extend it and it fails. And I've had this discussion with Dr. M several times about how many surgeries do you end up doing. So what I discussed with the patient was he was only symptomatic when laying down, so we can leave everything as it is. And he's now 3.5 months post-op and still evidence of the screw cutout, occasional back pain when laying down. So the next question, but at this point, he felt like he really couldn't be as active. He liked to go on his boat at the lake, and he wanted something done about that pain that kept coming on when he was laying backwards, and also sometimes now when he's lifting heavy since he's 3.5 months out from surgery. So we discussed treatment options, which was to continue with non-operative management, extension of his fusion, which we know carries a risk for more surgery, removal of his hardware, which was not a strong option because there was no strong evidence of fusion across his surgical site. And the last option was to consider enhancing his fusion with a lateral antibody at the top of the construct with a loosening where the screw was loose, and removal of all of the hardware later on after fusion, at least the posterior hardware. So he opted for the option of a lateral antibody fusion, which is what was done. So we did a lateral and placed him in a brace and pretty much waited for 14 months and got x-rays just to make sure he had not developed any adjacent stenosis, especially with all the motion, and also got a CT scan which confirmed that he had actually fused across the surgical site, and subsequently took the patient back to the operating room and removed all of the posterior hardware without extending him, and his pain was completely resolved, and that was the end of surgery for him. So this is also another case of could the surgery have been the technique that was used, understanding his bone quality, retrospectively going back to measure his Hounsfield unit on his preoperative CT scan, despite the bone quality feeling good during surgery. I think those are things that probably would have shown that he wasn't necessarily a great candidate for the surgery that was performed.
Manny, what biologic did you use in the D-lift and also in the earlier A-lift?
Infuse.
And Manny, did you consider using cement for the screws once you found the first one to be really bad?
So the two screws at the level that was initially fused, L45 screws were not great, but the S1 screw and the top screws were good. So I thought maybe we can get away with this and not have to add and not have to cement it. But clearly that wasn't a great option.
Well, hindsight's always best, huh?
Well, we really appreciate, nobody loves showing the complications, but, we all need to see them. And we're all going to have them. And Bob, I was going to tell you, it was a great old guys lecture. That should be like mandatory showing day one of your spine fellowship and the last day, but maybe day one of your spine practice and the last day also to kind of put everything in perspective. So thank you for sharing all that stuff.
Jack.
It's always a pleasure.
Yeah, it was great. Great talk, great cases, and you never disappoint.
I
So
like your tie.
Thanks. 23 years. 23 years, Scott. Yeah.
That's awesome.
Thank
Wow.
you.
Nice.
Thank
you,
you,
guys.
gentlemen. Thank you,
Happy
gentlemen.
holiday. Happy
Happy
holiday,
Always a
everybody.
pleasure. Thank you all.
Thank you.
all right, Bob,
Always.
stay
Manny.
warm.
Everybody stay
Manny,
safe.
don't sweat too much.
Yeah, I gotta
All
go
right,
shovel
everybody.
some snow.
Ooh.
Yeah.
All right.
All right.